And Good morning, Dr. Farqui, Dr. Kiltz.
Good morning.
How's everyone doing today? Starting another live Fertile Fireside Chat. It is, let's see, what is the date? 16th May. Wow. Already. Time is zipping by. I hope everyone's doing well today. We got a little fire back there, trying to get it, although it's warming up a little bit. Disappearing. Hello, Mrs. Anderson, Janine. Hello. It's Chloe. Hello. Valentina Hernan, didn't get the whole thing. Sorry about that. It's a beautiful day. And let's see, Hippie Fitness. Good morning. Good morning, Mrs. Anderson. Again, a good morning to all. Kaylee, Cynthia, Brenda. How are you guys? And Leela. Let's see. YouTube, Instagram, Facebook. We've been throwing some stuff out there on TikTok. I'm working on a lot of new videos, a lot of stuff that we can all learn some new ways.
Jeanne, bonjour, Dr. Farqui.
Bonjour. So whether you're coming from Montreal or anywhere in Canada, the U.S.,
are all over the world.
All over the world.
Yeah, our patients are coming from all over the world, literally.
And excitement. We're closing on Sarasota tomorrow. We'll be hopefully up and running within the next 2 months, at least, for monitoring and consults, ultrasounds and bloods and things like that. But we're hoping to have our IVF center in Sarasota within the next 4 to 6 months and running.
At this point, there's no going back. It's really happening.
It is absolutely happening. So we're really excited about that. Yeah. Let's see. Samantha Simpson, hysteroscopy. Dr. Magany found 2 polyps, went to have them removed. Apparently one disappeared. It could have accidentally come out with that first hysteroscopy, but we are going to be pushing for hysteroscopies in Colorado to be done both diagnostically and therapeutically. So we're really excited about that also coming up. Let's see. Kissy, you want to get, let's see, Albany, 39 eggs, 9 fertilized. We're really here to continue to integrate Eastern and Western and bringing affordable fertility to everyone. And just, again, adding lots of new things. And I've learned from Dr. Farqui. We've been working together for over 20 years.
Actually 26.
26.
27.
Woo.
The first 6 years were a blur, right?
The last 26 years have been a blur. Now 65 and 25, so it's kind of really amazing how we're doing here. Yes, Florida, Sarasota, we're working on a Miami monitoring, but we have some really great docs already in Miami doing monitoring for us. So we're kind of balancing that out a little bit.
Well, I mean, as the need comes, we're going to grow. It's all part of
Canada. So, let's see.
Can we reach you from Canada?
Well,
let me answer that one. You can call CNY right here in the United States, and they can refer you back to CNY Canada depending on what you need. It's you don't worry about it. Just reach out to anyone at CNY, and it's going to happen. That's the way it's done.
Once we make an appointment for you, make an appointment in our Colorado, in our Albany, in our Syracuse, in our Montreal, and Dr. Farqui is able to help with monitoring. You don't have to do a secondary consultation. It's already there. We're all working together no matter where you are in this world, by the way. Let's see. The process 4 times now with no success. What do I do to help my situation out? I have been in remission of stage 4 breast cancer for 2 years now. Christina Cuetas. Well, I think if we're not already talking already, but take a look at the family building guide on Amazon, look at our website, but we want to try to reduce inflammation to try to help what's ever going on with your eggs. If your ovaries are still functional, well, even doing some ovulation induction, IUI or IVF, but this is where IVF and donor eggs may come in, but we'd be glad to review that for you for sure. Hey, Meg, how you doing? Thanks to our whole nurse practitioner, PAs, all of our practitioners. Our nurses are amazing. Thanks to, let's see, Bridget, Larissa, Kayla, one of our NPs, Marnie, at Meg. I mean, we just have amazing, great team members at all of our locations, and we're all learning. We're all working to do our very, very best with you and everyone else. And so at times in this journey, it doesn't go the way we all expected. We're going to look and work on trying to make it better the next time. But, this is the problem with medicine. It's very imperfect, and we're just all working together to try to answer the questions more appropriately. Let's see, Joanna Lopez.
Hi, Dr. Farqui. Just wanted to thank you for being such a kind and amazing doctor. That's me.
You? No. This isn't the Dr. Farqui I know. But again, let's see. This week, Dr. Banerjee and Dr. Corley are going to be in Syracuse. Dr. Maggs is in Colorado. Dr. Verdialis in our Atlanta. We're working on Atlanta with Dr. V. Really excited about that also. And let's see. I'm taking the week off. I'm going to be stopping into Colorado for a few days, Thursday, Friday, Saturday, to visit, but I'm on a vacation. I'm really kind of trying to work to keep this thing on the down low because I need a little bit of R&R to reset and get you guys already, get you more and more information, do better. All right. Erica Chelsea. First night of LDN, last night, retrieval in June. I had some insomnia, jitters, bouncing thoughts. Well, that sounds like all of us. It's common. It usually gets better. If you just started the LDN, it's going to take a little time. You'll get a little better at it. There's a great book on Amazon, the LDN book. Big fan of low-dose naltrexone. I've seen so much improvement. And you could actually try it in the morning. Yes, good point. I find that some people just don't tolerate it. And the other is half the dose. I've been trying the 3 milligrams over the 4.5 milligrams, but there's lots of good ways to do this for sure. Let's see. Kaylin Anumudu. Hi, Kaylin. Is there another way to help follicles grow more evenly before starting stims on the birth control? This is where I think estrase. I don't like to use the birth control pills. I'd rather use estrogen and prometrium for maybe 2 to 4 weeks with or without some human growth hormone for priming. And then the other is you might even use some Lupron in the luteal phase.
Yeah, I do that too.
And then convert it. Yeah. Right. So we do a lot of that.
It's a kind of like a hybrid long cycle that turns into a antagonist cycle.
Right. Yeah. So we usually will start the Lupron a week or two before your period with the estrogen progesterone, and then stop it when we start your stims or with your period. But you got to stop the estrogen progesterone in order to get a period, if we're planning a fresh cycle. But in my opinion, if you're looking at doing a freeze-all cycle, then it might be a little bit better. But yes, we do that for sure.
Look at that one there. From someone wants to call us from.
Yes, we talk to people from Pakistan, Bangladesh, India, all over the world. We use WhatsApp a lot also, Skype, Zoom, all of these are ways. If you go to our website, you can make an appointment. We'll get you in with one of our providers.
Yeah, and I mean, you can also specifically request, because I speak Indian, if you want me to talk to you in Indian, you could specifically request that, and I'll take care of that.
Yeah, and Dr. Banerjee also can help with that.
Yeah, he also speaks Indian.
Yes,
too. That's right. We're two Indians.
Right. But we again, all of our providers can help take care of you from around the globe, and we can help get you your proper treatment. We do a lot of reproductive immunology. We're working with Dr. Vidali, Dr. Braverman, God rest his soul, great, amazing guy, gives us a lot of great information on how to better approach the immunologic causes of all this. Let's see, ovarian bloom sold out. Ebony, I will get more ovarian bloom. We're just really going to be getting a ton more, and I really apologize that. Let's see, this is where DHEA, CoQ10, fish oil are really, I think, important. And kiltz's keto lifestyle. What I recommend is 1 meal a day. Get off the treadmill, add the fat. Remember, if you're vegan, vegetarian, cook the carbs well, increase the fat, and 1 meal a day will help that a lot. But I'm talking to Will, and Will's promising me plenty of ovarian bloom and all of these things. And so we're going to get a lot more. So thank you very much Let's see. Recovery time, Amy Hucker. Recovery time suggested after polypectomy.
There's not much of a recovery time, to be honest with you. If you do the polypectomy in a very minimally invasive way, we could probably get going the next cycle. How about you? Is that what you said?
Yeah, I would say that you do the hysteroscopy, DNC, or hysteroscopy polypectomy, and then go right into a cycle after that. We sometimes will thin out the lining. Polyps are so pervasive for so many people. So we really want to kind of...
Actually, let me add something. A lot of polyps actually occur because of our treatment. And we have to be always watching out for that too. Because
well, estrogen, estrogen, but a lot of it is, right. We're adding the estrogen, you get that estrogen stimulation of the uterine lining, but ultimately inflammation is the trigger, and the estrogen. So the inflammation is a trigger. Estrogen is the fuel.
Yeah,
that is perpetuated, and some people get it more commonly, don't they?
And in those patients, we do see more incidents of inflammation. That's a good question there over there. I have a hydrosalpinx. Any recommendations? Well, that's a pretty straightforward situation. First of all, it's not easy to fix hydrosalpinx. We used to do that a lot in the 80s and 90s because we didn't have high success rates.
I didn't practice in the 80s and 90s.
Well, you never practiced.
Right. Okay. I'm too young.
You just do it. So back then we used to fix them and we had like dismal results. And today we don't even bother fixing it because it's really not fixable. You're better off without them because it actually hinders your fertility when we put the embryos back because there's fluid in the hydrosalpinx.
So we recommend removing the hydrosalpinx via laparoscopy, laparotomy, and sometimes just transection will help a lot in all of this. Nature's Woman, Balastra, Ugoma, hello, Katerina, hello. We're just grateful everyone's joining. Share, send them to all your friends and family members. We have a lot to share that isn't just fertility, but it's health and wellness overall.
I have a question here, which I will answer very differently. The question is from Christina. What medications can I take to help my body have a positive outcome for IVF? Actually, the answer to that is not medications. It's what thoughts can I have? Lots
on faith and thinking. That's a good one,
because
doctor.
Now it's hard to imagine. We do a lot of IVF cycles, but we have come to the conclusion over all these years, your mind controls outcome way more than we've ever dreamt.
Everything.
And we're not very intelligent people, but we see this so much.
I'm not. You are.
No. Neither of us are. But we see it so much that we can't help but to believe it because there's so much evidence that this is true. That
I wrote a book called The Fertile Secret, which was taken from The Secret from Rhonda Byrne, is thoughts create things. And so the more you focus and have faith and belief in the thing you desire, as if it is, it shall be. So hold that. It's a really tough journey. Find some spiritual texts to read and to foster in your mind. And then a lot of it, if you look at the Fertile Feast or Kiltz's Keto Lifestyle or the Family Building Guide, there's a lot on massage, acupuncture, prayer, on ketogenic anti-inflammatory lifestyles. Again, it doesn't matter if you're a vegan or a carnivore, there's ways to reduce inflammation without drugs. Ovarian bloom, molecular fertility supplements. Now, in fact, supplements in some way are a drug. I'm sorry, drugs all come from plants originally. And so that's something that really, really to keep in mind. But we do a lot of things like acupuncture, yoga. Aaron McCullough's Yoga for Fertility is really great. Fertile Hope Yoga our new offering on the Fertile Spirit, which Danielle's putting together and bringing a lot of people that are helping us through the stressful journey because we need someone to talk to about this. So it's always our pleasure. How do you lower? There's a question I want to get back to it. Reducing MCHS 0501 about testosterone and how to lower those testosterone levels in all of this. What's the cause of higher testosterone levels?
Tell us.
Well, it's prediabetes, it's metabolic disorders, it's PCOS, which in general, it's a high carb, low fat diet. And we're eating too many carbs, which ultimately stimulate insulin, and insulin also is an androgenic stimulator. That's one of the biggest cofactors. Plus, many of the plants we eat contain estrogens, progestins, and androgens. And so it may be that we're consuming the androgens, and that's a big factor. But
well, I mean, definitely what you eat has a very significant effect on your ovarian function.
It's it.
And high insulin levels do mess up the ovaries and make them produce more testosterone. It's maybe a little bit of a simplification, but it's not far from the truth.
Well, it is simple. It's Occam's razor is the simple answer is what. And the more I think we realize how simple it all is, the better I think we could approach this. And that's a lot of what we worked on in our family building guide and so many of the books that we write about and talk about that I think are important. The other is for some people, if they take a low dose steroid, that'll help. And certainly maybe metformin and inositol, but keto is the one. Lila Escobar, Dr. Fruki, you want to get this one over here?
Yep. 43 years young, first retrieval with 225 of gonal-F and 20 of HCG, 4 eggs, all immature. Second protocol was 450 and 150, so we cranked up the dose here. Never retrieved due to testing positive for COVID. That's too bad. But did end up with 3 follicles, 18, 20, and 22. Those are good. What would be my third protocol? Maybe 300 and 150 of gonal-F. Thoughts, please, doctor.
Well, go ahead, doctor.
Ultimately, if your ovarian reserve is low, high dose or low dose protocol is going to end up giving you more or less the same results. We believe that when you use low dose protocols, we pick up better quality eggs because they're more responsive. High dose protocols tend to just pick up any follicle. That's maybe the immature thing there. If you had a good ovarian reserve, then you're going to respond well. But everybody has a threshold beyond which they will not respond, even if we increase dosing.
So the higher dose doesn't matter so much, but a duo and triple stem. So unfortunately, the COVID, if you haven't gotten the vaccine, I'm recommending the vaccine before you try to conceive, get it, in my opinion. But I would say a duo triple stem might have gotten you mature eggs that time. We see some people that have immature eggs 1 month and the next month they do great. And the why part of it is the mystery. But again, it's omnitrope, human growth, keto, LDN, CBD, and the ovarian bloom and the molecular fertility supplements. And we're going to be continuously investing into getting more of those supplements and supplies out there because we really think they boost a lot.
And also we need to get them in Canada because Canadian patients are asking for it.
Well, that's Canada. So that's, we're that's a whole COVID and problem with Canada as much as anything. But you can always travel across to our Buffalo office and we'll have the supplies for you. So thank you very much. And again, don't give up. That's one of the most important points in this, by the way. Let's see. Maria Cruz, go ahead.
I have a lot of gas in my belly and they could not see my follicles in the left ovary in my sono. And I'm in a stage of ovarian stimulation. Well, ultrasound, air is a big problem in ultrasound. It does cut the sounds out and we're not able to see. But there's always other ways we could come around and see it. And that brings us to there are cases where people have difficulties doing retrieval, and we do so many of them that we're able to come around that. And sometimes we do abdominal retrievals because we can't see anything on the vaginal approach. Sometimes we call in a colleague who helps us help positions the ovary so we can do the retrievals. There's many ways we can go around that.
Well, and a lot of, again, once in stimulation, sometimes it's harder in the monitoring, but when we get to retrieval and you're sound asleep, we kind of manipulate things a little bit that we're able vaginal or abdominally get those eggs out for sure.
And in fact, it's very rare that we're not able to get the eggs.
It is. But and there are going to be a few cases you can't, but it's rare, by the way. All right, Summer Engel, 6. Get surgery from a hydrosalpinx block tube, low vitamin D, high AMH. Suggest IVF with those issues. Let's see.
Still have
tubes, but not great tubes.
Well, that comes back to the previous question. Number one, high AMH is good. Low vitamin D is relatively easy to correct just with supplementation. and our supplements also. When you do IVF, it's not going to affect your response if you have your tubes or not. But when you're going to put back your embryos, it might make a difference, because that fluid that we were talking about earlier is inflammatory fluid. So it just calls in all the inflammatory cells, and the poor embryo doesn't have a chance.
So in essence, the hydrosalpinx and damage is due to inflammation. You got to get the inflammation down. So go to our family building guide, or kiltz's keto, or the Fertile Feast. And this is where you want to reduce the inflammation. It'll help make better environment, which will make better eggs and a better environment for implantation. But ovarian bloom, the molecular fertility male and female supplements are helpful in all of this. And it may be I've also done a month of the antimicrobial, which is the Levaquin, Flagyl, Valtrex, and Diflucan is a good protocol, and to see how that works for sure. And all right, let's get this one, doctor.
I'm supposed to call circuits on the first day of my cycle. I cannot produce a cycle despite this. This is a new. I've been on Provera 10 days, estradiol 14, then on Provera 10 again. I'm 33, FSH, LH normal in March. Do we even really need a cycle to start a stem?
Call the office, tell them you don't get regular cycles, and kiltz said, come in, get an ultrasound and blood work. That's it. If you have a thick lining and we're going to freeze all, it doesn't matter. Right. If you have a thick lining, we're trying to do a fresh cycle, well, then we either do a DNC, if the estrogen progesterone isn't working. But again, I think the most important part is I don't get regular cycles, get an ultrasound and blood work. I'm reminding my entire team members, it's not call with your period. It's if you don't have regular periods, let's get you an ultrasound and blood work, and then we'll get you going from there.
I got a good question right here.
What you got?
From Melissa right here.
Yeah.
What's the age limit for an embryo transfer to have a healthy pregnancy?
I don't know that answer. No one does.
Well, they're actually 60.
No, but we don't even know that because donor egg embryos and a healthy, I'm 65 and I see plenty of 65-year-olds and 70-year-olds that are extremely healthy today.
Well, there's in India, there's a lady who's 78,
with
twins.
Right. So again, if you're healthy otherwise, then the possibility is there. Don't give up. We're open.
I mean, we above 45, we will do some tests. We make sure you have a mammogram. We make sure you have a good cardiac function and things like that.
But we should be doing it for everyone. We want to make sure you're all healthy.
And we have tons of experience with patients having children later in life. I mean, like really a lot.
Plenty of women in their 60s.
Yeah,
absolutely.
And I don't know if we see anything. I mean, we watch them closer, but it's doable.
No, they're very healthy today. I mean, as we get into the 60s, we know and feel how healthy we are today.
Well, the older we get, everyone else starts looking younger to us.
Well, you're 25, right?
I used to be. Well, I know I've been 25 for a couple of years now.
And all right, Nahid, always 80-90% fertilization rate. I did strict keto for a year, took some supplements, did mini IVF, 11 eggs, but only 2 fertilized. These are the challenges of this fertility world. Why, you can be doing all the right things, but we're still haven't overcome whatever damage was already done. This is the challenge. Plus, even in natural fertility, it's a 20% delivery rate per cycle on average.
20 years old.
That's right. So there's something going on, but this is where laparoscopy, hysteroscopy for endo, they call it silent, but if you're infertile, endometriosis isn't silent. It's screaming at us. You can do either the surgical approach to endo or the medical approach, which is Orlissa, letrozole, or Lupron, letrozole for 2 months. And don't forget the antihistamine, the antimicrobial, and of course, kiltz's keto lifestyle. We've seen so much benefits, but again, one cycle may not be so good. The next one is perfect. That is the truth to this. But again, why part of it? Something is causing this in our bodies. It's an unknown. We're here to help give you the tools to help, but unfortunately, we're not God, but we're all gods in one way or another. So don't give up, as Janine MTL and we're all going to jump in. And Sima Pierre,
good morning.
good morning. Sona
Muchtin.
He's
Hello.
much better at reading these than I am. I apologize.
Well, you got a name like Faez Farqui. You
Yeah,
can read these.
yes,
Not
yes.
Rob Kiltz is
Well, no one can get that one. Let's see. You guys are amazing. Let's see. Supposed to call first day of a cycle and have medications ready, but call them ASAP. Get your, and you want to have your medications in hand. And listen, you don't have to start the medications the first, second, or third day of your cycle. Technically, any day of the cycle could happen, especially if it's a freeze-all cycle.
Here's a good question right here.
All right.
So I'm 43, endometriosis stage 3. I had a laparoscopy, a myomectomy, a polypectomy, all done in 2019. And I had a fresh transfer and it failed. How would you recommend proceeding after that? Well, and that's from Brenda Lee. Well, I mean, right away, I can see here inflammation is a big halt because endometriosis is synonymous with inflammation.
And I believe endometriosis is just another bowel disorder. It's bowel inflammation.
And it's an immune dysregulation. So with a history like that, I would go straight to an immune protocol. How about you?
I think so. Look at our immune 3 and 4 protocols at IVIG, Humira.
Yeah.
There's Plaquenil, Neupogen, Prednisone, Lovenox in higher doses. And don't forget, it's something's causing all of this in your body. But why one cycle works and another one doesn't, it's our mystery, because we have people who get pregnant with one cycle, have a baby, and then we go back to the same cycle and it doesn't work. Our bodies are always changing in a different environment.
We're constantly asking this question ourselves. I know our patients ask us this too, but we're also asking these questions ourselves. And one of the things that seems to be a breakthrough is immunology, because it's still not even accepted by all REIs. Do you believe that?
Oh,
but it definitely is a game player in this thing, and to address that has been a game changer in our practice. We've had patients who have not got pregnant after 5-6 transfers, and we do an immune protocol. Is it just a coincidence? Maybe not, because it's happening very, very often.
It's our immune system and inflammation that's really the driver.
That's a huge player in fertility.
Yep, for sure. Recommending
Accessa instead of myomectomy.
Well, let's see. Let's see.
Diva's pampering.
Thank you. It's certainly, it may be reasonable. We're mostly doing myomectomies, but that may be one way, and it may be okay.
I have some thoughts about new procedures. There's a lot of new procedures that come along. I'm not saying that they're bad, because we have to be open. We actually do a lot of new stuff.
Absolutely.
But
absolutely.
We also keep in mind that a lot of new stuff that we do, after a couple of times, we stop doing it because we are not sure of the outcomes. When you have something so important as fertility, I think I would just go the old school way, the best way, handle those fibroids, and then move on and get your baby. Because doing these new procedures where we have very little experience, outcomes are not known, I don't know.
Well,
I'd be a little hesitant.
A little bit, but
but it's not bad.
But the question comes, if you do that procedure, then it's going to hamper ability to take it out later. It might, but I'm a little leery to the freezing, the microwaving, the heating.
We don't know yet.
We do some ablation or embolizations, but I think it could be an issue. I'm not supporting it currently, but open-minded to it.
Yeah, I think we should do it for a while on patients who are not looking at fertility to see outcomes, and then bring it into the fertility.
And there are going to be some people that spontaneously conceive and deliver a baby with those, but I do know embolizations. There have been plenty of people have delivered, so I think I'm open to it. Let's see. Rebecca Davis. This is a long one. Hi, Rebecca. How you doing? Let's see. I'm not sure I got all of that.
You want me to read it?
Let's see. She had some infections after delivery, got pregnant again and did a hysteroscopy for IVF, was successful in 2018. Infection again, but caught early. Another hysteroscopy with minimal web scarring, bottom of the uterus. The first had webbing, FET in February, and a miscarriage. So, this is where, again, back to inflammation, right?
Yeah. Well, that's definitely inflammation.
Yeah. Well, it's the obvious, but it's the not so obvious. All disease, it's got its foundation in inflammation. That's really it. But maybe, again, a course of antibiotics early on, maybe doing the month of the microbial protocol, the antihistamine protocol, as a reasonable approach to that. What do you think?
Yes. I suffered from miscarriage due to low progesterone. What would be the best protocol for me? I was looking at number 3. What do you think about progesterone levels and miscarriages?
Well, it is either what is the egg, chicken or the egg. So it may be an abnormal environment and ovulation that led to a low progesterone, or sometimes these pregnancies that are abnormal for some reason or another lead to low progesterones. But at the end of the day, this is where the anti-inflammatory protocols, this is where adding more progesterone, helping ovulation can be, I think, a big win in that case.
Yeah, and when we do progesterone supplementation and IVF and embryo transfers, we're giving multiple times the dose that you really need. That's something you do need to know.
But
and then we're measuring it.
But if we're measuring it's low, add to it.
Yeah, we do.
But we got to do a little bit better on that for sure. Chances. Let's see. Noel Lilo, hello. What are the best What are the chances of conceiving naturally after miscarriage? Success on fresh transfer, but sadly my cervix opened at 17 weeks. You need a cerclage.
I was going to say that.
Need a cerclage.
Very, very important.
Get it. Look at the antimicrobial, anti-inflammatory protocols. That's probably the biggest thing.
I got another question about that.
Yeah.
How long would you wait after miscarriage? Because that's another question a lot of people ask us.
A month or 2 at most.
Yeah, definitely not 6 months.
I don't think you need to wait 6 months.
No, definitely not.
But after a myomectomy or bigger surgeries or a longer term, later term loss, then maybe 3 to 6 months. Even after a big myomectomy, I just do 3 months.
I do too. I'm bolder than you here.
Timmy L's.
By the time you deliver, it's been a year, right? And the uterus doesn't start getting stretched out and all that.
Well, delivery. I mean, I'm an Irish. Well, my brother's an Irish twin. He was born just a year after I was born, so it didn't take long. The uterus is really an amazing organ, so we know that it's certainly possible. Poor responder, low AMH. What is my deal? Okay, so this idea of poor and good responders with a normal AMH, the AMH doesn't always tell us how you're going to respond or if you're going to get pregnant or not. It's just another marker. But plenty of women, despite all normal numbers, only make 1 or 2 or 3 eggs and embryos. You got to be cognizant. That's just the nature of the game.
Yeah, but lifestyle change here. That would be
always lifestyle change.
No, but that right there is the perfect example. Do a lifestyle change. There may be a reason why you're not responding very well.
Right.
And it's not necessarily got to do with fertility. It might be with diet, it might be with insulin levels, it might be with all kinds of things.
Yeah, absolutely. Yeah. So lifestyle change, but the recognition that some people only make a few eggs. IVF, we have this idea that everyone's supposed to make 10 to 20 eggs. It's not true. 2 to 4 eggs to get 1 to 3, 2 embryos may be all it takes. This is where natural cycles, very low dose, minimal cycles can really be a game changer, I think. So it might be something to look at. Is just go that route. But certainly kiltz keto lifestyle, fasting, a better mindset to all of this. But again, you can do much higher doses. You might make more duo, triple stims. I've seen it work. So just because you only get a few 1 time or 2 times doesn't mean the next time isn't gonna change it up. Jessica, hello. Low AMH 0.2, 34, IVF success previously 32 with the 0.47, 6 eggs, 3 fertilized, 2 made it to blast. Second embryo failed. What are the chances of getting pregnant again? They're still excellent and good. These numbers don't say you will or you won't. Okay, less likely or more likely, but lifestyle changes, right, Dr. Farqui?
Yep.
And for me, it's always what you put in your mouth is what matters. And mind in the mouth matters most. Will make the big changes.
It has a much bigger impact than people will think. It doesn't sound scientific, but it is true.
Well,
it is very
but
true.
It's science. It's all science. It's all spirit and it's all science, right?
It's because it's not what they taught us.
Yes.
This is not what they taught us, but it is happening.
The ivory tower sometimes has it wrong, right? But I've seen plenty of 0.2 AMHs have babies. And, I've seen plenty of normal everything where it doesn't work. So let's not get caught up on these numbers. What we want to do is be persistent, have faith, a more positive attitude. And
how do you look at a failure? Is that something it's a lesson?
It's stepping stones.
Yes.
Stepping stones.
It's a lesson. And every failure teaches us something.
It always does.
Results eventually in a success.
Kat Bradley, thanks for joining us again. How you doing today? 28, Hashimoto's, low sperm, good motility, 78%, good morphology.
Awesome. That's good. Yeah.
and do you try naturally? Always try naturally, right?
Yeah.
Always try natural. You got to always be doing natural, I say.
Well, first, if you mention Hashimoto's there, just make sure your thyroid is also well controlled.
And Hashimoto's is caused by
inflammation.
It's just one of the most common organs to get damaged in our bodies. It's very, very sensitive.
The ovary might be the other common organ.
Well, it is.
We can't recognize it, but I suspect
our reproductive organs, testicles and ovaries, are very, very, very susceptible to inflammation for sure. And don't forget that when someone says to me, I'm healthy but infertile, that means you're not as healthy as you think you are. Again, we get in the mirror, we do our weight, and we think, oh my God, I'm so healthy. But that's not a very good marker of health, in my opinion. Let's see. Let's get that out of here. Get back to that. 36 opt for 2 fresh transfer instead of 1 fresh, and then frozen transfer instead of, let's see. A lot of times you're doing that first cycle. I recommend 1 embryo. Over 35, we talk about 2. Even younger, we'll discuss it. It's not a recommendation, but do the 1 with fresh and maybe 2 with frozen. But again, it's individually discussed, and it's not a.
There's no recipe.
There's no recipe. There isn't?
Also, it depends on day 3 and day 5. That's another issue there.
It does. And we do a lot of day 3s. So cleavage stage is day 2, 3, and 4. Blast stage is day 5, 6, and 7. We do them all. There's not one way for everyone. Unique and different for everyone. All right. Let's see here. Amber, let's grab that one. You want to get that, Dr. Carlton?
Yeah. So when progesterone level goes from 40 to 312 in 4 days, and E2 goes up instead of down from a transfer, is this a sign the baby has stuck? Well, it's a good indicator, but it does not mean you're pregnant. And I see so many with E2s under 500 and progesterones in 20, 30 whose transfers have worked. Once again, all these blood levels don't necessarily indicate that it's going to work or not. There's a lot of overlap. Even the blood levels.
It's a huge gap in these numbers. They're all over the place. And so these are just numbers that we're just trying to gauge whether or not to up your dose or lower your dose, right. But they don't mean I'm going to get pregnant or I'm not going to get pregnant. Right. For sure. These are small factors, but we like to take a look at it. But you'll look at a lot of people with the numbers, and then the question is, well, did it work? Okay, it worked. And then the progesterone management of your body and estrogen management from your body is another factor that I think is something that we don't understand.
To this day, there are people that still debate whether we should even add progesterone. It's just so you know that, there's doctors who are convinced we don't need it, and they might be somewhat right too. I'll tell you a story about a patient of mine.
Tell me a story, doctor. Yeah. Please tell us all.
This lady had multiple IVF cycles, and finally it's one of our patients. So the husband flew up here on his plane from Montreal to have an IVF cycle, and he had told us this is the last IVF cycle, and we're going to do egg donation. So once we transferred the embryo, they flew to New York City, and she went shopping. She forgot to take her progesterone, completely forgot it. And I mean, she's done it so many times, but she forgot it. You know what they had?
A beautiful baby.
A daughter.
Yeah.
Yeah. So
a beautiful baby.
Yeah. So don't get tied up in numbers. It's there's more to it.
But we do order these numbers, and we're there to manage them and help them be a little bit better. But a lot of times, you know, the why part of this, that's the mystery. There's so much mystery in all of this, and that's the magic in some ways. And so that's why faith is so important, and patience in the faith. Let's see. Not a girl key. Do you recommend embryo testing? I'm 35 and suffer recurring miscarriages. I'm still not a big fan of embryo testing. My general recommendation, though, with the miscarriage, test the embryos. That'll give you some sense of it. But this is where our full immune protocols come in and keto comes in. But if you test an embryo and it never gets in a uterus, you never know why or whether or not it's going to make a baby or not.
Do you know, I just have a thought here. When you have a miscarriage, the majority of times, the reason for that miscarriage is an abnormal embryo. But that's when you have a miscarriage. When you keep having recurrent miscarriages, I'm not sure it's the embryo. It could be something else.
Well, but the cause of all damage is inflammation.
Yeah.
So the cause of a miscarriage isn't a bad embryo, it's inflammation that leads to bad sperm, bad eggs, bad embryo, if that's the case. But ultimately, we want to change the environment of those things. And there is evidence that embryos can correct themselves. So again, and so we see so many embryos with such a myriad of abnormalities. Then we want, and it's a placental biopsy anyway. It's not even the baby. And so I've put in abnormal embryos and got normal babies, and we put in normal embryos and got abnormal miscarriages. Yeah. I'm not seeing abnormal babies because they're not implanting or they're miscarrying. So in my opinion, we do a lot of PGS testing. So, and I'm supporting what you want. And sometimes there's a reason to do that, but quite often, should you do it? You can do it. If you have a lot of embryos and you're trying to select the more likely embryos to implant, then that's a reasonable option in all this. Let's see, Amber Carlton, you want to get this again?
How similar is a 4 to 8 and 2 to 9 embryo at day 3? What's the percentage of transplant both together? You get
well, it's a grading.
It's 8-cell and a 9-cell embryo.
But it's a grading issue. I'm not a big gradier. I think grading is bad. Bad.
So if we thought PGS was difficult, this is the next level of trying to explain that it isn't.
But
because there was a recent article, we talked about it in the last Facebook Live, where they looked at all these embryos that were graded poorly and the pregnancy rates in those embryos, and they were very, very high. So at the end of the day,
I was a poorly graded embryo, I'm sure.
Me too.
And they wanted to throw me out. Thankfully, my dad and mom, said, okay, we'll give this guy a chance.
Yeah. Actually, we don't throw embryos, do we?
Ooh, they're not our embryos.
No.
They're your embryos.
And we never know which one is the one that'll be the baby. And very often we've gone through a bunch of embryos in a patient, transferred all the best ones, and we're down to the worst embryo. That's the one that gave them their baby.
Colon cleanse, Shanti. I think absolutely the colon, in my opinion, the large intestine is the major site of inflammation. That's why kiltz's keto and 1 meal a day, I think, is a game changer. Get rid of fiber, cook your carbs well, add the fat. And I think probiotics are not good for us. But I think the colon cleanse may help reduce inflammation. Fasting, and water. It should be our fluid, not alcohol, not much tea, and certainly not much coffee, but get rid of alcohol for sure and eat less frequently. Let's see. Antihistamine protocol during priming or stim. Start it right away. You could start it during priming, even 2 to 4 weeks prior to starting your cycle. The antihistamine antimicrobial can be very helpful also. First IVF, what day do you usually trigger? Well, 16 to 18 millimeters on average for the majority of the follicles is our trigger time. Sometimes we're pushing them a little later. That could be day 8, day 9, day 10, day 11, day 12. It's stimulation and follicle size that matter probably more than anything. Wouldn't you say, Dr. Farqui?
Yeah. Days don't. And it doesn't matter what your normal cycle length was before the IVF cycle. We're monitoring you for a reason. And it's so that we can determine based on follicular size when to trigger you. It's not the days.
You want to get Canelo Powers?
Yep. If you're 39, if you're 39 and have failed a transfer and only have a 4AA embryo left, would you suggest an ERA, Alice, Emma, before your next transfer? If you can afford it, absolutely. I think
it's about $1,000. We're doing the ERP through Cooper, the ERA through iGenomics. I think it's a reasonable thing. Think about laparoscopy, hysteroscopy for endo. Look at our lifestyle and our immune protocols. I think those are all. But yes, the ERA is something to absolutely consider in all this.
Alice, Emma are the two complementary tests with the ERA. Look for the DNA of bacteria in your endometrium.
Is that through the U.S.?
We do that in Canada.
Well, that's
so it's called endometrio when you do the three together. And
I haven't seen it in the U.S.
Yeah.
So
they look for the DNA of the bacteria in the endometrium, which brings out the pathogenic bacteria, and they look for the microbiome of the endometrium. Endometrium is not sterile.
Well,
so they look for microbiome.
So this is where the antimicrobial protocol, I think, comes in for everyone.
Yeah.
And remember, keto is an anti-inflammatory. And in my opinion, again, our endometrium, the endometrial biopsy with a pathology can help a lot in that. But we see so much inflammation, you almost don't even have to do that. You know it's there and adding that. But the ERP and the ERA are certainly things that we do recommend and you may as well think about getting them early before you do your first transfer as an option in this journey.
That's a really good question out there.
Go ahead.
So it's Oksana and Diagal. Diagals. Journey to baby. Journey to baby. Okay.
Right.
So would you recommend not to do PGT testing and just transfer the embryos as is? So far, we have had one cycle, PGT testing, and all embryos came back abnormal. Well, first of all, I hope you didn't throw them away. That's the number one thing. Here's the evidence. Once we started doing PGT, we were all gung-ho on it. And but we began to realize that how come in this group of patients we're getting less babies? That's when someone came up with, hey, wait a minute, are we throwing away babies with doing PGT? So they started biopsying the actual embryos. Earlier we said we were biopsying the placenta. If you biopsy the embryo, it's in an experiment.
The inner cell mass.
Yeah. And 15 to 20% of abnormal embryos are actually normal. We don't know which ones. And they could be terribly abnormal on the outside and still be normal. Are they correcting themselves? Or were they just normal and we didn't pick it up? Who knows?
Or our tests are imperfect. And that's it. I mean, so our testing in medicine is imperfect and we have to recognize that.
Yeah, so PGT is a tool, but it's not a black and white tool.
Right.
It has to be used in its context. Now, what would you do if you had a patient like Journey to Baby and they come to us and say, these are my abnormal embryos. What do you do? Well,
they want to transfer them. We're okay with that because since science is imperfect and every embryo should have a chance to become a baby. And again, we see so many untested embryos that we transfer all day long. We're not getting a bunch of abnormal babies born. They're not happening.
No.
So something is amiss in all of this. That I do know. Frozen next time, or try to get them to blast and said, let's see, Faria. I would say it doesn't matter. You could transfer day 3 or wait to blast. They're both equally successful, in my opinion. That's your choice. But I think if you froze them on day 3, you either thaw and transfer them or thaw and take them to blast. Both of those are options. We have so many choices in here. The question is, which is the right one? Well, it turns out to be the one that works. And then we say, gee, we should have done that before, or the first one worked because we did it right. But why it works and doesn't work, it's still our biggest mystery. Let's see here. John, completely unrelated, success rate for the embryo surviving the unthawing process. About 98, 99% of those embryos, right?
Well, since we changed our way of freezing them, years ago, we used to do what's called a slow freeze. Now it's a different technique. Our survival rates have
tremendous, 98 to 99%.
I mean, we rarely see them not survive.
Right. Good one for you, Dr. Farqui.
Good morning. Thank you, Dr. Farqui, for an amazing retrieval yesterday. Dr. Kiltz, what's your intake on my transferring 2? I'm 30 stage 4 endo and had surgery with you in March.
I would still recommend the 1 embryo. If it's your first transfer, if it's your 3rd or 4th, 2 is okay. Second is the we're on the fence. It's not a straight answer, but
there actually is no right answer. We got to look at your history. We have to assess the risk of ending up with twins, because twins is not necessarily the best outcome.
No.
And then we have to look at what's your chance of getting pregnant, what's your chance of getting twins. Let's try to maximize your pregnancy and minimize the twin rate.
All right, Big Montemail. So nutrition helps undergoing. Nutrition is critical for all of us. And if you read Kiltz's Keto Lifestyle or the Fertile Feast or the Family Building Guide that talk way too much about nutrition, to me, number one is fasting. I recommend 1 meal a day. That's the biggest, most important game changer. Eliminate alcohol, any significant caffeine or tea, reduce it, keep it low to no. And in my opinion, keto, which is a high fat, low carb diet, no carb, is the game changer. And we have no requirements for carbohydrates in our diet ever. Now, it's true, we eat like omnivores. That's what we've come to over these years. But look at our molecular fertility supplements, and if you go to Kiltz's Keto Lifestyle or the Family Building Guide, lots of great stuff in there. I hope you'll find that helpful. You can go to Amazon and get those all on Amazon.
You're absolutely right. We have no requirements for carbohydrate. There are populations in this world that, for instance, the Inuits, they live in the Arctic. There is no carbohydrates out there. There's just meat and fat.
And that's what they were eating.
They were fine until we started giving them carbohydrates. Now they have diabetes, hypertension. They got all these diseases that we all have. So if you want to prove that diet is a big player in diseases, there you go.
Well, I mean, what goes in our minds and our mouths is the cause of our diseases. And we know that. Faulty thinking or faulty bowels. And so, plants are live organisms that don't want to be eaten either. And they figured out how to kill us and disrupt our reproduction, which is really, really crazy. Alicia, absolutely. Alicia Cole, thank you. Keto always. And in my opinion, once you're pregnant, it's even more important. Stay on low-dose naltrexone, and keto is kick-ass, the most amazing thing I've learned personally, and I've shared it, and I've seen so much great outcome. If you read about polar bears and black bears and bears in general, and so many organisms that go on long fasting, my opinion, fat is the only fuel for every cell, including the brain. And red blood cells are just a little battery that eventually run out of fuel and they die, and then they're recycled. What we don't realize is that the cause of disease is a high plant-based, low-fat diet, which is critical. So once you're pregnant, the most important time is to stay Kiltz's keto or some, and look at Marie Emmerich and some others.
There's a question about male fertility. Lorena right there. So that's a good question, by the way. Any recommendations for someone who may potentially have male infertility, diets or supplements? Yes to diets and yes to supplements.
So our molecular fertility supplements, I don't know if we're going to get this right, a little higher there. The molecular fertility supplements, too white, maybe it'll come. I don't know if it's going to work on this. Molecular
There you go.
Fertility
Yeah.
is our supplements for the male, and low-dose naltrexone for the male, and cool the body down. Get off the treadmill. And remember, even if everything looks normal on the male side and the female side, it's always the sperm, it's always the egg, it's always the embryo.
Because you can have normal sperm. Let's talk about sperm. You can have normal sperm. We can do a semen analysis. It's going to be perfectly normal. And you're going to have DNA damage in that sperm from oxidative stress. That's another way of saying inflammation.
Well, it's glycation. It's glycation.
So how do the supplements help? Well, first of all, they contain elements that are useful in sperm production, but they also protect the sperm with antioxidants, which somehow improve the DNA. But too much of that too is not good.
But the real issue to me is we're adding all these antioxidants. Well, why don't we just stop putting the things that cause the oxidative damage in the first place? And so that is really the key. Like, it's sort of, we do all these smoothies and shakes and things that ultimately contain they contain sugar, and we're doing it, which is the leading cause. But so always the male, always the female, always the sperm, always the egg, always the embryo, and always implantation. And so we're learning from so many people out there how to do this. But we're doing a video on the male factor, so really excited about that. But it really is, it's the same thing for the guy as the gal.
Yeah.
Sperm source and egg source, right?
Exactly.
How's everyone doing today? You doing okay, Dr. Fertility?
Yeah, it's a beautiful day here.
I'm going down to Orlando for the week and maybe out to Colorado for a few days, the end of the week. I'm off this next week. I'm going to be turning this thing as down as I can. Dr. Fruki's back up to Montreal, but he'll be here in a couple of weeks again. We have Dr. Corley, Dr. Banerjee in Syracuse. Dr. Kondrup is joining us this coming week, so I'm really excited about him. He'll be manning our Sarasota location at Doctor's Hospital, doing surgeries for endometriosis, fibroids, and fertility care. So we're really excited about that. Pharaoh Oneness, hello. Let's see. And let's see. Kimmy XO88 is 1 to 2 months prior to cycle, too late to start keto. The day you get pregnant is the right time to start keto. Kiltz's keto lifestyle is always start today. No matter where you're at in this journey, it is the most amazing thing I've ever learned. Keto changes everything in the mind, and it's all about these two places, right? It's like our mind is down here, but remember the brain is in the bowels, but it's the driver, right? 3 months prior to having effect. Again, for me, 2 weeks before I saw my effect, it was the most amazing thing. Sherlyn, how you doing? Let's see. 10 weeks, twins. Oh my God, amazing. Keto. And low dose. Sherlyn, 10-220. Tell Dr. Maggs, 10-220. Dr. Banerjee, 10-220. Dr. Chang and Dr. D'Souza, 10-220. Yeah. He knows I'm very neurotic at all of this. And look, we have so many different protocols. And instead of the birth control pill, estrase prometrium, far better. I don't like the birth control pill personally at all.
Well, the reason is that when you stop the birth control pill, it in many patients, the inhibition does not go away that fast. And we end up with less eggs, less everything.
And it's synthetic. The birth control pill it's the one that increases your risk of strokes and blood clots, not estrase and prometrium. And so my opinion is I don't like to use it. We try not to use it at all. Kimberly, you want to get that one, doctor?
Should I be concerned if I have fibroids? What do you think, Rob? That's a big question.
Well, so fibroids or tumors are indications of inflammation. They in and of themselves can be a factor in your fertility. I've seen so many times where we remove them and voila. So if you have fibroids and you're infertile, it's an issue. Now, if you have fibroids and you're not infertile, you have no other problems, well, it may not be an issue at all and they don't need to be removed. But in my opinion, I've seen so many people with these fibroids that are in the 1.5 to 2.5 millimeter range or 2.5 centimeter range that I've simply removed them.
Well,
and they
let's take it even further. We had patients coming and saying, well, they told us this fibroid is not affecting my fertility and we don't need to remove it. And we still removed it. And the patient gets pregnant.
That's right. And they do better. And so I think it's something that we need to always keep.
I think we need to expand our view of fibroids.
Well, all of us do. So if you have fibroids, polyps, endometriosis, scar tissue, those are all outcomes of inflammation. And remember, your inflammation started before you were born. Your mother likely ate a high carb, high plant-based diet, which contains poisons, chemicals, antigens, and it's all sugar, which ultimately crosses the placental barrier and it damages your body. It crosses all organ systems. And this may be what ultimately is the leading source of our damage and disease because it's in the air, in the water, in the food, but it's not what the industry is spraying on all that. It's what nature makes, because nature ultimately, all of it wants to survive and thrive, and we're all food for someone or something, which is kind of crazy in this, isn't it? Birth control, estrase and prometrium, ESTRACE, prometrium. Those are the ones that I recommend.
It's the same as your natural estrogen and the same as your natural
progesterone, which is where we should be going in all this. Reciprocal IVF have lower success rates, or same reciprocal. So it depends on where you're getting your egg source from and what the environment is. But there's no higher or lower results of that. It's all related to what's going on in your body. No matter your gender, your size, your shape, your age, your weight, your color, or whatever your description is, we at CNY Fertility are here to help you. And it's a challenge in this life, in this world. But number one, have faith. And remember, fatty, fertile foods first, and fasting is 1 meal a day. Let's see, it's 11 o'clock. One more quick question, Dr. Farqui. What do you think? Melissa, Supernova, how can you manage stress?
Why the heck did you pick such a complicated question? Okay, so everybody has stress.
I have none.
Well, I'll tell you why he doesn't. Everybody has stress. Everybody's living a life with all kinds of things happening to us day in and day out. So it's not what's happening outside of us that helps us manage stress. It's what's happening inside of us. The real universe is inside of us. It's how you choose to react to stress. If you feel that the stress is damaging you, you chose to feel that. That's the only way you can manage stress, is to manage it from within. You cannot change life outside of yourself. You have no control of that. So learn to manage your stress inside.
So you actually have control of everything in your life via your thoughts. And I do a lot of journaling. I recommend journaling for everyone. Start the day early. I get up early, 3:30, 4 o'clock. I start meditation, 4:35. I do a daily inspirational thing that I needed to help me, but yoga, meditation, prayer, read a book, listen to something uplifting and positive every day. That's really important. Go for a walk. For me, I also do pottery and painting.
Have friends.
Have
friends. Because one of the ways I manage my stress, I have Rob.
We have to have friends to talk to. We talk about our problems. And we go visit my mom and dad in Lakeview Cemetery in Skinny Atlas. And we just take a walk and we talk to them. Yeah. And my mom always tells me she has no problems and she wants to listen to mine. And so we share our problems with our family members, our friends, our partners, or just, again, share them with yourself is really important. But this is where our new fertile spirit comes in. But we all need to manage our stress and struggles. But sometimes you have to imagine that they're actually there for a good reason. Dr. Farqui says that these are stepping stones, not our stumbling blocks. So that's really, really, really important for all of us to recognize that this journey is full of problems and failures and issues. But this is where learning to manage stress. I just wrote a book called Living Your Best Life, or The Fertile Secret. And I write these things because who needs to manage his stress more than anyone? Right?
Yeah.
Right. And this is why I love to work with Dr. Corley and Dr. Lutheringer and all of our docs and team members. And but number one is faith, faith, faith. And that's critical. Pescatarians can do keto, by the way, and keto and fasting, absolutely important. Let's see. When expect, so let's say, I always say Monday for Sarasota, but let's say August 1st. But again, we got Dr. Conop's getting some training and we're hiring new team members. Dr. Farqui is going to be helping down in Sarasota also. So it all is imagined to get our closing and get some construction stuff, but we're really excited about it, by the way. And Dr. Farqui is amazing.
Thank you.
We're just, again, we're all so grateful working together, and let's all keep doing uterine massages and fasting and faithing and all of this. So, and yes, you guys, you don't have to do kiltz. You don't have to do keto at all. Listen, we're just giving you ideas. We have to formulate and adjust to what you need, not what we need or want. And so know that. So again, so many people, I'm just sharing ideas of what you might try. But if you don't, it's okay. We love you guys. We're so grateful. And I too learn from all of my patients, whether they believe in God or not, or they're vegans or carnivores. It doesn't matter. We're all learning together. Wouldn't you say, Dr. Farqui?
Yeah. Every day we learn something.
Dr. Corley rocks is true. Atlanta. I'm working on Atlanta with Dr. Verdialis. Thank you, Dr. Verdialis. We're all working together to get that happening. So that's critical. And don't forget, God bless you guys. We'll see you guys next week, Sunday, fireside chat. Hopefully, Dr. Farqui, we can join in one way or another. Dr. Fink also, by the way,
yes,
is new with us. So I'll see you guys. God bless.
Take care.
Bye, guys. Thank you. Bye, Kelly, Jeanette, Kimberly, Crystal. Love you guys.